Hi, just waiting for Lynsey and Juliette to just join and then we can start.
Excellent, thank you. Shamin, Lorraine Sanduza will be coming along at 1:45.
Okay.
Could you send her an invite so she can join directly?
Yes, I'll send it to her now.
Thank you. As a panelist, yeah?
Hi everyone, how's the sound? Is that okay? Can everyone hear us? Good. Welcome back to the third series in our series, third case in our series of fictional COVID cases. So this session's for all our junior doctors, our staff grades and our consultants to learn and share experiences on managing coronavirus in mental health settings. This week we're also welcoming doctors from North East London, Norfolk and Suffolk and West London NHS Foundation Trust. We want to open this week's webinar with very best wishes to all at home and in hospital with coronavirus. We've had lots of requests in the last few weeks for a session on dementia. And so this week we're looking at an older adult patient. We're talking about some of the medical management of COVID and discussion around referring into the acute trusts. In the coming weeks, we also have some excellent liaison and perinatal cases lined up. And as ever, we welcome your comments in the chat box. I want to thank our geriatrician colleagues, Sana Mufti, Joe Preston, Claire Dow, Ian Wilkinson, palliative care consultant Caroline Sterling, Waleed Fawzi, Shevonne Metheikan and Paul Gallagher this week. And also Emma Higgins, nurse from the Homerton, who's been fantastic in advising us. And again, huge thanks to our presenters, Cate Bailey and Lynsey McApline. They're both working in very busy inpatient jobs, as well as producing these cases each week. So thanks for that. You may be wondering now why Cate is setting fire to a cake. It's because it's Lynsey's birthday today, and she's chosen to be here with us. So if we can all take a 20-second hand wash to say happy birthday to Lynsey.
Oh, thanks, guys. I don't want to like spread corona all over it by blowing the candle out.
Happy birthday, Lynsey!
Okay. Thank you, guys. Thank you. Dear one.
Happy birthday! Lynsey, you're very lucky to share a birthday with somebody else who's very important. Me.
Is he talking now?
Sorry, go on.
Yes, I says you're very lucky you share your birthday with somebody very important. Me.
Oh, happy birthday, Paul.
Thank you.
And my mum. That's nice.
Okay.
Okay. Order.
All right. Over to you.
Back to business then. All right. Welcome back for case 3. All right. Okay. So
I think this is quite a good tweet, and I want us to bear this in mind, because I think it captures things quite well. I think bear this in mind as we're talking through this one. This was one of the hardest cases to write because there really was not any kind of unifying agreement on how best to manage this situation. So it's really a thing that's in flux. So we thank Jonathan Tomlinson, lovely Hackney GP, for this very wise tweet. And we keep that in mind as we go on. Our regular update in terms of things from last week. So this should probably be a rolling agenda item, PPE and resus. So we have Resus Council guidance and our recent ELFT guidance that is that we shouldn't really be doing resuscitation without full aerosol generating PPE. That's what the AGP stands for. However, towards the end of last week, gov.uk has updated and saying that CPR is not aerosol generating. So essentially it remains up in the air, like COVID.
Have you been planning that all week?
Yeah. So basically we don't have an answer, and maybe Paul will give us an update later about PPE. But yeah, so there's some links there, and a link to last week's slides, which of course we'll be sharing towards the end of this week. So updates from last week as well. Roth scores came up in our discussions, and although weren't something that we necessarily recommended, we've got new information now that really suggests that they shouldn't replace a proper clinical assessment. It was a very idealistic, nice idea that GPs were going to be able to use these as a kind of alternative to kind of getting a SATS probe on someone, but Tricia Greenhall has kind of led on an evidence-based review of this and found that actually it's probably not appropriate to use them as an alternative, and there's particularly the problem is that they will in about 1 in 5 people find someone as having estimating normal when actually they've got low SATs, which is obviously not something that we want in our situation. And I suppose further to that, we're seeing increasing reports of people who are having presentations where they're kind of normal sort of rate of speech and feeling kind of clinically okay, but actually having very low SATs, and those are people that we should still be worried about. So essentially we need to be monitoring SATs as part of a holistic assessment, and the BMJ 10-minute assessment is still quite helpful in framing that. So, do you have anything else to add?
No, I think that probably covers it from updates.
And I suppose the other thing to say about the case as we go through, because we often get a lot of feedback in people saying, oh, I think I read this somewhere that this might be true or this might be wrong. So please do get in touch with us and do contribute to the web chat. But if you have references for things, that's really, really helpful to let us know, because there's so much information at the moment.
We're all hearing lots of things on WhatsApp without much of an evidence base for it. So.
Yeah. So on to this week. So this week you're on the dementia ward, and you and your consultant are going to review your new admission, Mr. C, who is an 85-year-old man with mixed dementia who's been recently admitted, detained on a Section 2 after attempting to hit a carer in his home. So the background is that he'd been referred to the CMHT last week with concerns from his neighbours. They'd noticed him kind of wandering around outside the pub, which of course is now closed, and he'd been going there for his meals. The neighbours had been trying to drop food around, but he'd been shouting at them to go away. Social care had approved a urgent care package, and this had kind of started with shopping, meals, medication, but he then threatened the carer with his walking stick. Turn phones off! So he threatened his carer with a walking stick, and he was taken to A&E. So diagnosed with mixed dementia in late 2018, started Donepezil at that time, and during the DMC assessment it was noted that he didn't have any mental health history prior to that. He's got hypertension, type 2 diabetes, osteoarthritis, had an NSTEMI, and has second class heart failure. Second class? That's not what I meant. Class 2.
Class 2.
First class. Nobody wants first class heart failure. So he's on donepezil, metformin, ramipril, atorvastatin, aspirin, bisoprolol, but probably hasn't been taking these. So he worked as a hospital porter, was born in Grenada, moved to the UK in the 50s. His wife died earlier this year, so he'd been living alone since that time. And he's got a daughter who lives quite far away in Bristol, but still keeps in touch by phone and manages his bills. So he was independent with basic ADLs, but really has probably had a decline because actually perhaps his wife had been doing more for him than people realised. He's an ex-smoker, doesn't really drink very much, no illicit substance misuse. So when he gets to A&E, he gets quite a thorough assessment, and he's actually clinically quite well at that time. So he's slightly hypertensive, but he's not febrile. He's quite disorientated and has an AMTS of 3 out of 10. He's not reporting a cough, but he may be an unreliable historian, and he isn't observed to have a cough. And he's got a slight anemia, but a normal white cell count. He's got a stable renal impairment with a little bit of dehydration, but not too far off his baseline. And they do another CT and it shows that he's had basically progression of atrophy and moderate small vessel disease. They're doing everything, which is great. They're doing an ECG for us, lovely. If we can get that scanned into the notes, that's even better. So he's had a sinus rhythm and a rate of 80 with no acute changes. So he's medically cleared at that point. The advice is to encourage him to have oral fluids because he's a little bit dry. Look at his metformin dose, although he hasn't really been taking it, and to recheck his bloods the following day. So we're now on the dementia ward. Mr. C is still disorientated, thinks he's at work, awaiting further instructions, but he's actually quite settled. He's getting along fine with the nursing staff and he's eating and drinking well. And again, his observations are pretty much within normal limits. So you're off to see this patient with your consultant. So what PPE is required, if any? And we'll move on to the second question next. So if you're getting ready to see him, let us know what PPE you would be looking for. Is it working?
You've gone quiet on us, guys. Any thoughts on what PPE you should be thinking about for this patient? Oh, here we go. Okay.
All right.
All right. So we're getting a bit of a so we're getting a bit of a range. People saying full PPE. Helpful to clarify what you mean by full because there are different types. Lots of people saying apron, gloves, and mask. Face mask and gloves, surgical masks. Yeah, it seems like there's a bit of a consensus. Some people suggesting visors as well. And some people just saying standard PPE.
And just a suggestion, if you can, when you're typing, say to all panelists and attendees, and that way everyone else can see your responses rather than just us, much as we like to spread them as well. So this is something else I worked on for quite a long time, to PPE or not to PPE. So this is just a reminder of what our PPE looks like at the moment. And we're going to move on to the new guidance that came out again towards the end of last week, which is the reason that we're now wearing, or hopefully most people are wearing, all people are wearing PPE when they're seeing any patients. And that's because we're all kind of going within 2 meters, providing care to people. So it's single-use gloves, disposable plastic apron, and a fluid-resistant surgical mask. I want to see, it just looks so much like seasonal use there, but it's sessional use. And it's, I guess, up to you how long a session happens to be. But if it's getting sweaty or kind of, yeah, you might want to change it. And then the iron face protection is kind of a risk assessment. This is just further guidance about kind of resident, any setting basically. So that's why we're all kind of wearing PPE now, hopefully. This is just, I suppose, something to think about, and something I've noticed already on the wards, is that it is pretty weird to be approached by a whole bunch of doctors in PPE, especially if you're already kind of mentally unwell and a bit paranoid. So some of these doctors are kind of trying things like putting their photographs on. I don't know if you guys have kind of thought of any good ways, because the other thing is that people can't even see you smile. So all of the things that you normally do to reassure people that you're kind of a friendly presence and not a threat is kind of taken away. And it's amazing how much you lose in terms of communication when you take away your face.
Yeah, I find we're using a lot more hand gestures on the ward now than I ever would have before.
Yeah. So if anyone has any kind of tips on how they're managing that, then do get in touch and tweet about it. So this is what we thought needed to be reviewed. So we thought, obviously, when you're kind of seeing a new person, you're going to review their mental state, you're going to do a systems review, just a bit of screening given COVID. Physical examination, if that hasn't been done already, look at his medication, have an immediate plan in place, speak to relatives and find out kind of about collateral history, if there's any LPAs or advanced decisions in place. And the question of DNACPR is one that we're going to sort of discuss. So in terms of what he's like now, he's much the same on the ward as he was during the mental health act assessment and in A&E, so he doesn't really recall the incident. Thinks some people have been stealing from his flat. He's got some word finding difficulties and a bit of irritability, and he's disorientated. Doesn't have any insight into his memory problems. Thinks he's 35 years old, and again still thinks he's at work, but looks kind of again clinically well. And his daughter on the phone says that there's been a gradual decline, so we don't think that this behaviour and the kind of paranoia is really related to a delirium. He's actually been kind of gradually deteriorating, becoming a little bit more paranoid. And the daughter confirms that there isn't any LPA in place or advanced decisions to refuse treatment. So, DNACPR discussions are very topical on Twitter at the moment. Very kind of heated discussions going on, if anyone's been kind of keeping an eye on what's been happening about that. So is now the right time to be talking about DNACPR? Just to kind of remind ourselves that we're an SHO, we've got our consultant with us, we're reviewing a new patient who's got a moderate dementia on the dementia ward. Send us your thoughts.
So a few people saying yes. Some people saying maybe not appropriate for the SHO, but more appropriate if it's a consultant having that discussion. A few more people saying yes, but someone highlighting that it's not yet an issue. Okay, so we're getting a lot of discussions in that, around whether or not it's appropriate to be talking about it right now. Some people saying it's too early, others saying that maybe it's good to be doing it early and having that discussion in advance. People highlighting that it should certainly be a team decision and that the MDT and the family should be involved in that discussion.
Yeah, definitely. And I think probably, I suppose, as SHOs who get called in the middle of the night when the situation hasn't been discussed, I imagine it's helpful to know and that things have been flagged early. But let's have a think about what our guidance says. And I suppose the other question is kind of who should you be discussing this with? So that's, some of you have kind of answered that question already, but there are a few people that potentially we could be discussing it with, both from a professional point of view, but also, you know, are we going to talk to the patient about this, or are we going to talk to his family, or both? I don't know if any people have thoughts about that. Yep.
Yeah, so it seems like there's a bit of a consensus. We should be talking to the patient, talking to the family, talking to the MDT. Some people are beginning to ask if the patient has capacity at this point.
Yes, good question.
No, suddenly we're all asking about capacity. Great, glad that you brought that up.
Okay.
All right, shall we move on?
Yeah, absolutely. So the old age faculty have given some guidance on caring for older adults in the time of COVID, so it's worth kind of checking, and that's being updated fairly regularly. They've given some general advice which is kind of fairly sensible, which is obviously review your procedures, make sure you've got oxygen, check care plans and that sort of thing. So DNACPR could kind of broadly form that remit, although it is slightly different. So just to frame this, we're talking about kind of procedure or process where about 50% of people who have in-hospital arrest survive the initial resuscitation. 14 to 26 survive to leave hospital, and 10% are alive 1 year later. Those figures will vary, but these are a mix of figures from the Resus Council and from the NHS England HEE module on DNACPR. And that's, as far as I know, in hospital arrest, as in an acute hospital. So you could argue, and there are differences between weekends, nights and weekdays in the way that you would expect, where more people survive if they've been resuscitated in hours. And I don't know if anyone knows the answer to this, but I would hazard that the kind of outcomes for a mental health ward would be poorer than an acute medical hospital, just in terms of kind of our ability to respond quickly, get early CPR, get early defib and that sort of thing.
And I suppose that's going to depend as well on the individual psych ward and whether they've got access to the medical crash team or not.
Yeah, definitely. So essentially the advice from the HE module and the Resus Council is that CPR should not be attempted if it's unlikely to restart the person's heart, or it's not likely to add worthwhile benefit or sustainable benefit. It's not in accord with sustained wishes, and certainly not if there's an applicable advanced decision or an applicable DNACPR. But as you would also be aware, you need to be able to kind of see the DNACPR and know that it's actually valid and applicable. So the key things to think about when discussing this are the chance of success, and that's a medical kind of MDT decision, and the patient's capacity to be involved in decision-making or conversations. And overall, as you guys have mostly pointed out, the person who leads in the decision-making is the person who holds the overall clinical responsibility. So in our case, that would be the consultant psychiatrist responsible for the person's care. And in the community, the GP is obviously the person that is responsible. So these are the four sets of circumstances that are kind of described. So a reasonable chance of success and the person has capacity, in which case it's kind of unlikely that the person is going to suffer a cardiorespiratory arrest, and so there isn't really a decision to be made at that point in time necessarily, unless the patient kind of invites a conversation about that. However, if there's a progressive disease, then it's good practice to start conversations. And if a person with capacity refuses CPR, then that's a decision that should be respected. If there's a reasonable chance of success and the patient does not have capacity, that's when we have to go down the kind of IMCR best interests route, and involving those who maybe know the patient and know what their best interests are. The star against the IMCR is just that there's probably a huge delay in actually accessing IMCRs at this time. So that is one of the difficulties that we're facing. If there's no or negligible chance of success, as in by a medical definition, there is no obligation to provide treatment that is futile or burdensome. But again, it would be good practice to inform someone and have a discussion about that. But the kind of situation that we're talking about here with our gentleman, Mr. C, is a kind of no or negligible chance of success and the person does not have capacity. So again, it's a medical decision whether or not to offer CPR as a possible treatment. There is no need to then have an IMCR, but it's good practice obviously to inform the family and the person if it's appropriate to discuss that with them. So our trust guidance is kind of gives us some advice about DNACPR status and sort of offering these discussions and doing them sensitively, and that in the community setting, obviously the GP should be the one who completes the form and has the discussion with the person. And the Resus Council also reminds us that a decision should be reviewed when a person moves from one setting to another. So a move from the community into the acute hospital or the community into the mental health ward is a change in kind of needs and an opportunity to review these things. So it is obviously a complex conversation, and our guidance is that, we shouldn't be having these conversations by phone. Certainly, we probably shouldn't be having them by letter, as many of you have probably seen, again, in the news. But there is an understanding, of course, that, you know, some of these conversations are now going to be had on medical wards with people wearing PPE, but they're also going to be happening by phone because, you know, of relatives not being able to visit and that sort of thing. So the guidance is that there's kind of two parts to this conversation. There's kind of broadly trying to reach a shared understanding of the goals of care. And then there's also the aspect of the DNACPR. So you don't want to just go in and say, well, we're explaining that we're not going to give you CPR. You do want to kind of share information about how you've reached that decision, and also have discussions about goals of care more generally. But it's important that before you start a conversation about CPR, that you actually know in your own mind whether you as a doctor are offering it or not. And then that kind of informs the rest of the conversation. There's just some tips again, and there's a load of kind of resources on how to have these conversations, but essentially you don't want to be kind of asking questions like, would you want this to happen, if you're not going to offer it, because that's just unhelpful. And it's important to kind of stress that it doesn't mean that you're kind of hastening death in any way, because there's so many misconceptions about this.
Yeah, I think it's really important to be clear that you'll do all the other treatments up until the point of cardiac arrest. I think people think that when we say DNACPR, we're just going to leave people in a room with absolutely no support or treatment. Yeah. It's really important to be clear about that.
Yeah, definitely. And I think also explaining that actually the CPR only happens after someone's heart has already stopped beating. So the person is already dead at that point, and it's kind of that we're not going to try and do something after death. So there's lots of guidance on kind of how to have those conversations. And again, documenting not just the DNA CPR form, it needs to be documented in the patient's notes as well. The SPIKES model is a model for having difficult conversations. It's also a model for breaking bad news. So it's kind of helpful to use just if you're not used to having these kind of conversations. It's a framework, but again, I don't want to stress that we don't want SHOs thinking that they're having to have these conversations. This is more just for everyone's learning. This is really a kind of senior discussion. So what happens with Mr. C is that the consultant is able to speak to the daughter via phone. She's still really in shock from her mother, who died quite suddenly earlier this year. She's feeling quite guilty about not helping her father more, but she's stuck in Bristol and she's got young children. She's quite worried about what's going to happen to her father. Is he going to get COVID? Are there patients with COVID on the ward? And the kind of current provisions of care and isolation techniques are described to her, and the DNA CPR is explained. And there's a plan for some future discussions about ceiling of care, because it was quite a lot for her to take in at that time. So, is there anything else we need to say at this point?
I think before we cover all of that, let's move on.
So, of course, you're on call again over the weekend, because it's just how it is.
We're all on call all the time now.
And you are called to see Mr. C because he has low SATs. So what approach are you going to take at this point? I know this is a little bit like other scenarios, but we're just kind of, it's helpful to remind ourselves what kind of things do we want to kind of find out before we go. What are we thinking? Please share your thoughts with us.
All right, so some people talking about other obs, talking about PPE as well. And some people asking whether he has a temperature and thinking about whether or not we should be isolating him at this point.
Excellent. So yeah,
everyone's very concerned about his temperature.
Yes, absolutely.
Why?
So we want a full set of obs, and kind of where is he right now? Some things about his medical history, some of which we know because we know Mr. C so well now because he's our patient. So we will move on. So he's got, as we said, SATs of 89, respiratory rate of 24, temp of 38.2, and he's a bit tachycardic as well. He is confused but conscious. So people are saying that he should be isolated.
Some people say we should be doing a swab now as well.
Yep, cool. And PPE, of course.
Of course.
So just looking at news again, because it's kind of helpful. way of framing just how worried we should be, although it doesn't replace a full clinical assessment, obviously, but he's scoring quite high. I think, if I've calculated this correctly, he's scoring 8 on news, which tells us we should get there quite urgently. And there's some thoughts about whether he should just be transferred straight to acute care,
which I think is a fair question at this point.
Yes,
Definitely on my mind.
definitely. So what do people think might be going on with him without having seen him yet? What would you be wanting to try and rule out?
Yes, lots of people suspecting COVID. Also some questions about UTI, heart failure, pneumonia.
Definitely, and someone mentioned CCF as well, which is good, not because we don't want to forget that all of, you know, as we've said in all of the other, I was going to say episodes, that all of the other things can still happen. So he could get an exacerbation of CCF, he could get sepsis for some other reason, so we still need to be bearing those things in mind. Okay, so when we get to the ward, he's the nurses are saying that he's disorientated, a bit resistant, reduced food and fluid intake, but his obs were okay earlier this morning. So initially what we thought was get the nurses to apply the oxygen even before we get there, call the ambulance, get our PPE on, make sure others are wearing PPE, keep him in his room, repeat his obs with the oxygen on. So when we do get there, we're advised that there's going to be a 6-hour wait for the ambulance, probably not uncommon, your experiences. He's saturating then 93% with 5 litres of oxygen via face mask. He's still a bit tachycardic, he's still febrile, he's got some crackles in his chest, and transfer. So then we speak to the med reg and they are accepting the patient for transfer, and we have a call to the med reg. So just a bit of a segue now into communicating bad news by phone, because that's obviously something that we're probably doing quite a bit more than we normally do. There's a really good framework for this, which is from the NHS England online modules. Again, you know, I'm not going to go through all of it now, but it's a really helpful thing to kind of print out. The other thing is you can print it out and have it in front of you because you're making a phone call. So you can kind of make notes on the piece of paper, and this is quite a helpful way of kind of going through it. So it's all the kind of things you would probably think of. And same with kind of breaking bad news more generally, but it is quite helpful. Some of them obviously relate to death, so you don't want to be kind of communicating that if that's not the case. But the important one at the end is also about self-care, although that might have to be slightly delayed if the patient is still unstable. So again, if you're more of an infographic person, then by all means use this. Obviously replace the name. This guy's name is not Frank. So we're waiting for the ambulance to come, so we're going to want to keep quite a close eye on him. His observations are remaining much the same, so he's not deteriorating, but he's not getting any better. So the ambulance comes a little bit sooner than we expected, fantastic, but the patient's respiratory rate's now gone down to 20. He's pulling the oxygen off, and his sats off oxygen are 95%. His temps come down a little bit, and his pulse is 90. So the ambulance is refusing to convey the patient because he's not meeting the criteria for admission. So we call the med reg again, and they say the patient doesn't meet the criteria. They advise giving him some doxycycline and swabbing him for COVID and continuing to monitor him. So what do people think? Should he be admitted to hospital? Or does he meet the criteria?
Shall we go back and show his?
Yeah.
That's where he's at the moment. So we're getting a bit of a mix of opinions here. Some people saying that, you know, he's got a news of 8 earlier and we're querying sepsis, which would be an indication for admission. Some people saying yes, some people saying not yet. Some people pointing out that there has been some improvement on oxygen.
So tricky, but essentially some people also saying it's maybe not up to us. But I suppose what is up to us is how we advocate for our patients, and I guess that's where I suppose the message from the whole thing will be, you know, escalate concerns if you feel that the wrong decision has been made. But this one is kind of a bit on the cusp. So basically, obviously he was very unwell. Had the ambulance come sooner, he probably would have been taken to hospital, and then he would have settled in A&E and maybe been discharged from A&E. So we don't know. But looking at the guidance that we have, so had he made it to A&E front door, he would have been triaged. This is so cool. Lynsey did this. So he has probably a respiratory illness. And they define, this is the NHS England guidance, as if he's seriously ill, i.e. SATs less than 94 or news more than 3. It's not really clear if that's kind of over the last day or at that exact time, but I would say it's probably kind of at that exact time. So according to this, he would then kind of come under the not seriously ill area, perhaps, and then had a clinical assessment, maybe had a chest x-ray, maybe not. And then potentially, if he looked like he had COVID disease, he would have been advised to return if his dyspnea worsens. That's that side of things. Then we've got the NICE guidance about deciding about admission, which is kind of fairly balanced. It says, you know, actually, if we weren't in the middle of a pandemic, an older person who has COVID would probably be admitted because they're at very high risk of complications. But we are in a pandemic, and so actually you need to kind of have a risk-benefit kind of discussion and analysis. And it also depends on what kind of care can be offered where the person is now. So what they're talking about in terms of NICE guidelines, in terms of looking at severity, are these things, which are also including the BMJ infographic on kind of assessing breathlessness. They're talking about the CURB 65 tool, which is a tool for assessing pneumonia. However, again, that hasn't actually been validated in COVID-19. The NICE guidance is looking at oxygen saturations levels below 92%. So slight difference in terms of the NHS England, but if there's nothing else that you've noticed, there is inconsistency in guidelines. So it can still be a clinical decision or a kind of trust variation on decision. So what do we do now? We've still got him. He's kind of stable. He's not on oxygen. It's late in the afternoon now. Do we have any thoughts about kind of what we would do going forward? Might have to leave the doctor thing out.
Okay, so people pointing out that we need an escalation plan in case he deteriorates. People pointing out that we should still be isolating him and keeping his daughter in the loop about the fact that his situation is changing.
Okay. Yep. So, and questions about end of life pathways as well. So this is what we kind of thought, that we want to keep going with a set of OBS, regularly one-to-one nurse to keep an eye on him, a swab, take bloods, chest x-ray, depending on whether or not we actually have access to that. We want to monitor fluid and food intake. And the other thing is that we also are going to want to hand this person over to the night doctor to be aware of.
Absolutely. Some good suggestions here about doing a blood culture as well as the usual set of bloods if we're querying sepsis here.
Yeah, definitely. And yeah, so the next day, we're back on weekdays now. So there's an MDT discussion and he has remained kind of stable, but there's a concern that he's going to possibly further deteriorate. He's quite subdued, not very alert. There's some concerns about, you know, potential for aspiration. So do we think he should be transferred to the acute hospital if his SATs drop again? What do people think? Transfer. Yeah. Okay.
So generally people are saying yes, they probably would want to transfer if his SATs dropped again.
Yeah. Okay. So we're having some discussions with the ward. Obviously there's a lot of anxiety. We don't have continuous oxygen. So if he is going to have an oxygen requirement, that will run up pretty quickly. Consultant tries to get in touch with the daughter to discuss kind of what the goals of care are at this point. And there's also a discussion with the geriatricians, and the advice at this time is to transfer him if his SATs drop again, because there is treatment that they would probably give him in the hospital that we're not able to offer here, mainly oxygen, but also further investigations and treating reversible causes potentially. So just a bit of information about COVID in older adults. So the death rates are obviously very high for people aged 80 and above, and the hospital rates are quite high. But it's also true that there are people even in their 80s who are recovering from this. There are people, you know, you probably see them on Twitter, good news stories, people being wheeled out who have actually recovered from this. So we don't want to actually write off everyone who has COVID and has some respiratory distress. But obviously it does depend on other comorbidities and that sort of thing. And, you know, things like type 2 diabetes and congestive cardiac failure are obviously things that increase risk of death. Older adults are more likely to have respiratory distress and other organ failure, and they're also more likely to get a secondary bacterial infection. The Centre for Evidence-Based Medicine in Oxford is also kind of updating guidance constantly, but they argued that people who perhaps get early antibiotic treatment might do better. That's based on previous studies in older adults having pneumonia, not replicated obviously in COVID, but that's their suggestion. The other thing to be aware of with older adults is that there's often an atypical presentation, although I think we're probably increasingly seeing that atypical is normal for COVID, so who knows what an atypical presentation even is. But hypoactive delirium and diarrhea and abdominal symptoms can present as well. So, of course, that night, his SATs dropped to 70, only increasing to 80% on oxygen, and he is actually transferred this time. So this is what happens to him when he gets to the hospital. So you will have seen these, everyone's getting assessed for frailty at the front door. So over 65, they're using the clinical frailty scale. Really important for our patients is that if they're under 65, they should be assessed with an individualized assessment, not with the CFS, which we'll go into shortly. This is a very, I mean, it's a beautiful flow chart, but I'm still not sure if it really tells us all that much. If you are frail, then there will still be a decision about whether critical care is appropriate or not appropriate. And then there will be ward-based management and then decisions at moving on from there. But the frailty at least decides initially whether or not the person would go to critical care from the very beginning, depending on their clinical state, of course. And this is the frailty scale. We think our man would probably be somewhere around a 6. Just moving on quickly. So he gets admitted to the COVID ward. The decision is for ward-based care only with a trial of NIV. So they give him a go of CPAP. Our geriatricians were kind of divided on whether he would have had a trial of that. Some said yes, they'd give him a go. Others said no, probably we wouldn't do that in our trust. So again, variable. He's got bilateral infiltrates on his chest x-ray. He's got a new renal impairment, lymphocytopenia, raised CRP, and a raised troponin. So none of that is looking particularly good. His COVID swab comes back positive. So this is what BARTs are kind of using as a kind of daily care bundle or ward review for people, which I think, although some of these things like IV things are not helpful, I think it's a good framework for thinking also about our COVID patients, just to remind us of all of the different things. So these are the kind of things that the doctors will be looking at when they're looking after him on the COVID ward. So the next day, of course, you're on call again. Your exception reporting as well. It's important to note if you're staying after your shift. You're doing an evening shift in A&E liaison this time, just to mix it up, and you look up Mr. C's progress. He is continuing to have low SATs on the medical ward. He hasn't really tolerated the NIV, and he's now having palliative care. His section has been rescinded, and the medical team have been documenting attempts to contact his daughter. So just some information about kind of how breathlessness is going to be managed on the medical wards and potentially at some point on our wards as well. But at the moment, there is still the palliative care guidance suggests that oxygen can be appropriate even in end of life. But that's only if there's actual hypoxemia, not just, you know, if there's breathlessness. There are other ways to kind of manage breathlessness, as you can see there. But obviously there might also be a point in time where there's a decision to stop checking SATs, and that's kind of a different thing. But again, a discussion that you'd want to be having with palliative care and the medical team. So you're in the liaison office or the crisis hub, wherever you're based now, and you get a call from the older adult CMHT consultant saying that the daughter of Mr. C's been in touch with her, is really trying to get through to the medical ward, but she can't. And she's driven all the way from Bristol, and she's outside the hospital, and she wants to get in and see her father because she's heard that he's really unwell, but the security are saying that she's not allowed to visit. So can she visit her father on the medical ward?
Lots of people coming through saying no. Some people saying no, but that's a terrible thing to do.
Okay, so again, the palliative care guidelines say, of course, that people should continue to be allowed to visit, but kind of generally one at a time, wearing PPE. But I'm sure you've seen as well, of course, from news reports and so on, that people sometimes aren't being able to get access, and people are dying alone, but sometimes using videos to communicate. ITU is potentially a different scenario altogether as well, because of the high risk of aerosol generating procedures that are happening in there. But essentially check local guidance, because it is variable. At the moment, if patients are coming to the end of life, Homerton says that you are able to, but you have to have supplied a list of family members, and only one family member at a time wearing PPE can access. Again, Royal London, one member of the family wearing full PPE, and then a recommendation to self-isolate. So it's also really important that people are aware that they'll have to isolate after they've spent time with their dying relative.
Which may have implications if they want to go to the funeral, if they want to attend prayers after the death. So make sure they are aware of that.
Yeah, and it also depends on whether they're caring for other unwell older people at home, whether it's safe for them to be exposed. And ELFT, of course, Sally Sherman is where we have kind of our best information at the moment, or most experience, I suppose. The understanding is that it's a kind of risk decision for the relative, but again, still only ever one at a time with PPE, and, you know, increasingly trying to use video as a way of communicating wherever possible. So you clarify with the ward that the daughter is able to visit, and she is able to get up there, and she spends a little bit of time with him wearing PPE, and he dies peacefully at just before midnight. Do we have time, or should we?
We've got a few minutes.
Okay.
Good.
So again, something that we're hopefully not having to deal with too much at the moment, but there are very specific guidelines about how to deal with death in COVID, because obviously of the kind of risk of kind of infection. So there's very specific guidance about that, which we'll leave in the slides.
But worth pointing out that these are evolving and changing quite rapidly, so they're likely to change in the next few days. But do follow the links to see the most updated version of the guidance.
Yeah. So you're just on your way out of the hospital, and you're about to go home, but you run into Matt, who was the med reg, who you knew from medical school, and he was actually looking after your patient on the COVID ward, and he's been doing 12-hour shifts all week. He's very teary. What can we do to help Matt, if anything? Does anyone have any thoughts?
pointing out that we can help, but strictly no hugging. Try and be supportive from 2 meters away.
Yeah. PRN diazepam, it's a nice idea. So we're not going to have time to explore this too much, but we will be doing in a few weeks a case of a doctor who has is having some difficulties. But yeah, very sensible suggestions. So generally being supportive, trying to signpost to any other supports. Good idea about taking his number, because obviously you don't want to be spending too much time in close proximity to someone who's been on the hot ward.
Certainly not average.
I'm sure that's difficult for him, but yeah, definitely trying to offer support from afar. I think obviously we're all aware that it's difficult times, and it's actually normal to feel tired and overwhelmed, especially dealing with so much death and so on, and uncertainty. Some of you will have seen the study that came out of China, or the report about kind of what staff wanted at that time. So they didn't really want psychological help. They wanted the basics first, which again is all of the kind of guidance that we have about people who've been traumatized, is that they need kind of basic safety. And in this situation, it's about having enough PPE. It's about having rest without interruption. It's about knowing that your family is safe, and interestingly also about training to deal with patients who are anxious or refusing treatment or in quarantine or refusing quarantine, which is perhaps where liaison teams come in supporting staff. But huge number of resources available. I direct you to the Practitioners Health Programme website. There's lots of kind of informal support groups going on which people can kind of drop into. But again, just to stress, we're going to kind of explore this in much more detail with a proper case in a few weeks' time. So I think that's it. I guess our suggestions are really that we should always be discussing admission to the acute hospital if it's not clear that a kind of ceiling of care plan has been discussed, or that there's treatment that they may be able to offer that we can't offer, for example oxygen, or for their further assessments. So having a discussion is always helpful, and certainly with our older adults, speaking to the geriatricians is, they can obviously have a very balanced view in these situations. So that's the end.
Okay. All right, so that's everything for this week. We will be sharing the slides online as we always do, and I think Nita or Sharman will be posting a link to some feedback forms. Please keep sending us your suggestions for cases and things you want to cover. We can't cover everything all at once, but we will keep trying to cover the most urgent stuff. All right, thanks guys.
Thanks guys. I think we've lost Paul, but hopefully we might be able to hear from Lorraine Sandoza. I think she's going to come on to give us yeah.
Fantastic. So I'm Laura, Chief Nurse, some other of infection, and I've been managing the PPE. Can you not hear me? Oh, fantastic. PPE. So as you know, there was new guidance that came yesterday, last week Thursday, relating to what PPE we should be using. And it's on the basis of taking sort of a high precaution stance. So everybody, if you work with patients, you should be face-to-face with patients, you should be at the basic end wearing gloves, apron, and a fluid-resistant surgical mask. That's everywhere for everyone. The visors, like the goggles, are based on risk assessment. So it's relating to splashing, or in some of our mental health areas where we know that people have been spitting. What we want people to do is just think about basic infection control. So our CMHTs, if people are going to see people, you would wear your gloves and your aprons and the fluid-resistant mask. And after, when you're doing a depot, you would do the same. What the other thing is the PPE is, some of it is what we call sessional. So that means you can wear it over a certain period of time. So like the fluid resistant masks are up to 4 hours. Now we're getting quite a lot of questions about what if within 3 hours it gets soiled, you take it off. If it gets soiled within 5 minutes, you can take it off. The maximum time you can wear it is up to 4 hours. The gloves and the apron, if you're having contact, physical contact with the patient, you change it after every time you use it, as we would do in any session. And if you've been walking around the ward, touching surfaces, and then you have to go and touch a patient, you would wear new gloves, new aprons, and then after that, wear another set. We've got orders. We've now got a steady stream of ordering from a central point of view and things going to local services. Today, I've just finalized, I'm going to write a letter to every single member of staff in the trust. Will get a letter from me about PPE. And also I've written something separately for service directors and clinical directors about processes of ordering, where you can get what and how you can access help. Every day since yesterday, we're doing a 30-minute session with the infection control team as a webinar, I think from 4 o'clock, where it's just about PPE. So anyone can dial in to hear what they're saying. We've got some posters that should be with you in services, and I've ordered some more from public health, which are they've got infographics and they're quite easy to follow, because obviously in terms of donning and doffing, putting on and taking off of PPE, there's a certain order that helps lessen the risk of cross-contamination. The biggest challenge, and mainly within mental health, is about other infection control processes, like bare below the elbow, lack of jewelry and watches, and also even if you've been wearing gloves, making sure we wash our hands and we use alcohol gel. And that's something that we have not really been strict in within mental health wards, but we have to do that now. But all that stuff will be in the infographics and in the letter, and hopefully that will make it a bit clearer. There are other posters that if you're not sure where your area falls in, you can look at it to see what you wear all the time, what's single use, what's sessional use, and what's multiple use, like the goggles, for instance. They can be cleaned and used again. We've also taken a decision to supply staff with uniforms. Now, there's going to be varying uniforms across the trust. We've got scrubs, and also we've got polo shirts and trousers. So I hear some services have already got some scrubs, but I hear that the uniform is coming on Friday, so we will distribute it. There's a process that services have been asked in terms of sizes for everyone to get. I think we're trying to for at least 2 per person, so that will help as well. Sorry, I know I've just kind of spoken at you for ages. Are there any questions related to PPE? I can see some questions flashing. When you've got scrub from somewhere already, someone described something that I said, if you're not sure, can you contact our infection control team and they'll be able to advise whether you can continue using them. I think you should be able to, but I think Rana was saying she started asking me questions and I didn't know. So if you could contact them. In terms of all staff, we are prioritizing people who are in contact with patients all the time. So like I'm based at Trust Headquarters at the moment, so I don't need to get 2. Until every one of those staff has, then we'll be adding people. If you've got admin staff that go on towards, they should get uniforms as well. So anyone who goes into certain areas regularly should get uniforms as well. And then for the rest of us, if we're doing a one-off visit, we need to think about getting the PPE first. But if you're doing a one-off visit, you need to also think, is this really necessary for you to go on into that area as well? Oh, and the uniforms are not just for nurses, they're for all clinical staff who are working in clinical areas. So OTs, psychologists, doctors, everyone who's working in those areas will get a uniform. If you're an IAPT, I've been asked, and you're working from home, we will not give you a uniform. Sorry, Juliette, you know, the questions are flashing quickly and then they go, she said 2, I think. Yes. Do you mean 2 sets? Yes. I'm trying to give people at least 2 sets so that, yeah, you've got time to wash, because they can be washed in domestic washing machines at 60 degrees. When you get your uniform, we'll give you a little something in terms of how you sort of contain it.
Lorraine, people are asking about laundering the uniforms. Do we leave them at work or are we supposed to take them home?
You take them home. There's a process of how you bag them and have to wash them at least 60 degrees. Because we don't have, for infection control, we cannot mix our washing and service users washing. And if they go with sunlight, like what our duvets do, what we give them, we'll get something back. And with personal sizes, people have to give, we will give them, we will give you instructions on how to do it, how you take it off and how to put it away, and then how to launder them. We've ordered navy blue because when we do colors, navy blue is a color that everybody can wear. So we will fabulous. I saw that. Sorry, your questions are flashing quickly for me. So can I go? Oh, okay, sorry. Yes, everybody will need PPE. Everybody, from the guidance, everybody will need PPE, because what they're saying is there are lots of people who are spreading COVID who are asymptomatic. And if we only wear PPE for where we suspect, we've got another group that might have, but also we as staff might be positive, but are asymptomatic and are still coming into work. So that basic level, hopefully, will reduce infection spreading. Yes, the long gowns have been a problem across. I've been advised that we've got some now, so they'll be coming soon. The normal surgical mask, because I've been asked about FFP3, they are in shorter supply, but the normal surgical mask on a day-to-day does help. But in certain higher risk areas, we will be giving FFP3 masks. Fit testing is an issue. So Paul has agreed that we can have what's called fit checking, where you can check the fit of the masks. And that's until we can get everybody trained, because we cannot train everybody at the rate that it's needed. So something will be sent out about fit checking. $60 degrees. Washing should be 60 degrees.
And the webinar link?
I'll ask comms to send it. I think there was something yesterday in the comms, but I'll ask Rana and them. I was just at the infection control meeting just before I came. Can we borrow fit testers from a general hospital? Seems unfair. If they can spare fit testers, I think the issue, unfortunately, with equipment, with everything, is a massive increase in everybody wanting everything. So even with the PPE equipment, we were behind the queue because they would always give first preference to the acute hospitals because of the nature of the people who are being admitted. So we're going to, I'm speaking to Claire and the infection control team to see where we're at, because fit testing is still happening, but with the numbers that we've got in the trust, we cannot do everyone.
Okay. So, is that a question? No. Okay. I think we're being told that we have to wrap up.
Okay. So what I'll do is you'll get a letter. Hopefully it will say it will explain some of the stuff that we're doing. Every day we're focusing on PPE in our daily bulletins. So please keep an eye out on them. And I'll make sure that you get sent the link so that you can dial in. Yeah. Thank you, everyone.
Thanks for joining us. We're not going to answer all the questions today, so still keep bringing more questions. And yeah.
And if you want, you can copy and paste them and send them through, and then we can see how we do a response to them.
Yeah,
brilliant.
brilliant.
Okay, all right.
Thank you very much.
Okay, thank you. Bye. Bye.
Thanks,
Bye.
everyone.
Bye.
Thanks for joining us.
See you next
We're going to
week.
sign off. See you next week.
Okay.
Bye.
Bye.